ঠিক ঠিক ঠিক, yes.
ডক্টর ইকবাল কি প্রথম বলবেন নাকি?
আমাদের তো স্যার হচ্ছে যে এখানে আমাদের অপূর্বদা জয়েন করে ইন্ট্রোডাকশন দেওয়ার কথা ছিল।
অপূর্ব কোথায়?
সেটাই তো দেখতে পাচ্ছি না।
ও আবার আমাকে ফোন করে, আমি সবার আগে জয়েন করেছি। তাহলে আমি
আপনি স্যার আমাকে ইন্ট্রোডিউস করিয়ে দিন, তারপর আমি
শুরু করছি আছি তাহলে। So let us start today's webinar program. So it is a very pertinent issue, and you know, COVID pandemic has posed a challenging threat to all care providers. So at this crucial time, we need every discussion to work out our policy, and that is the need of the hour. So where is Dr. Iqbal?
Yes, sir.
So with this background in mind, we'll have to be very updated, and today's the webinar will focus on the salient points, and particularly the secondary infection. You know, COVID is the immunocompromised state. The T cell, B cell, all are at jeopardy. Cytokine storms. It makes a huge onslaught, and pulmonary infection then sometimes lead to pulmonary fibrosis, and post-COVID, you know, the myocarditis is not healed, some dysarrhythmia, and lot of morbidity and mortalities. So it is the challenge of today. So with this end in view, today's webinar is changed. So may I request Dr. Asif Iqbal, who is from Apollo Gleneagles Hospital. Dr. Iqbal has huge experience in the critical care, and I think Dr. Iqbal will enlighten us about his presentation. So I invite Dr. Iqbal to start his presentation. Dr. Iqbal, please. Dr. Iqbal, please.
Yes, sir. So, good evening, everybody. Today is a very today this pandemic situation. We have a lot of experience on COVID patient with sequelae of the COVID. And the most important things, the day of invention of the newer medication in the COVID, we saw a lot of secondary infection complication. So today we will discuss about the both bacterial infection as well as the secondary infection. Before that, I want to request Dr. Asok Sengupta sir. Sir, I'm audible to you?
Yes, audible.
So, Dr. Sengupta is our HOD, Department of Pulmonology in Apollo Gleneagles Hospital, and he has a lot of experience on the sequelae and also the complicated COVID case. So, sir, I will discuss with the first case. Then we will have the question answer session. Actually, I have made two presentations, one for the the MDR bacterial infection. Another is the invasive aspergillus after the COVID infection. So first case will be the bacterial infection, and sir, you will guide us if you want. If you want to stop somewhere and you want to focus anything, then you can, sir.
Okay, understood.
Yes, sir. So this is a 56-year obese male, hypertensive, on amlodipine 5 milligram for decade, diabetes mellitus, not on regular medication, and known hypothyroidism on L-troxin. His transfer from another hospital in the Jamshedpur with a low-grade fever, non-productive cough, progressive breathing difficulty, and no other associated symptom. And duration for the disease is 1 week. And alert, oriented, afebrile, baseline, mild tachycardia, hemodynamically stable, chest fine, craves, bilateral, 96% saturation on 5-liter oxygen in the emergency, and bipedal edema. So we have done ABG, and ABG showing that patient is hypoxic, and the X-ray showing that there is a bilateral pneumonic patches. So what the next for this patient? So provisional diagnosis of this patient in emergency, it may be LRTI. Differential diagnosis will be the acute heart failure, ACOPD, asthma. Due to the pandemic situation, we are focusing on the viral origin also. So do we send Procal? It is a debatable question at the entry of emergency or later on, but we have sent it the all necessary investigation for this patient, including procalcitonin and the CRP also, and COVID RT-PCR. So need any investigation at this point? CT, yes or no? These are the question arises, but we follow the protocol that we do the CT on presentation, those who are very hypoxic or those having symptom related to the pneumonia, especially due to this pandemic situation. So next, what is happening?
You just go to the straight to that slide. Yes or no?
Yes, sir. But this is not coming. Any idea from the back team? Hello?
No, it's coming. You just keep it forward.
Yeah. But yes.
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 Then yes. Then okay. This is the CT. CT-টা তো এখানে প্লে করা যাচ্ছে না, এটা কোথায়? ওকে স্যার, সিটিটা দেখাতে পারছি না, এখানে প্লে অপশনটা তো আসছে না, সরি। আদিত্য, তোর ব্যাক টিমকে বল, অসুবিধা ফেস করছি আমরা। So the other investigation, hemoglobin 9.3, total count is 8,900, procalcitonin 0.39, CRP is 32, the complete metabolic profile within negative limit, and sputum is negative. So though the comprehensive respiratory panel, we do not send every patient, due to the pandemic situation, we sent the COVID-19. The COVID-19 RT-PCR in this case it was positive. Then we shifted to this patient to the in the HDU, and we have started remdesivir, steroid, and the collection. We prefer the steroid, these things. We prefer the solumedrol instead of dexamethasone. Solumedrol, that is 1 milligram per kg. We start the starting dose, and then we started the conservative management in a HDU, and patient require NIV 50% FiO2, 14/8. So the IL-6 was 112, D-dimer is 1225, serum ferritin was 586, LDH is 225, and patient having day 7 of illness. Now the question arises whether we will give TOSI or CCP. The patient, I'm sorry to say that I'm not able to show you that video of the our CT scan. CT score is very high. So we have given this to this patient both CCP because day 7 of illness and also the tocilizumab. And on the day 10, there is a alert-oriented afebrile, decreased shortness of breath, and the heart rate is. তুই কি দেখাতে পারবি? আচ্ছা ভিডিওটা ওখানে যে ভিডিওটা sir, can I go back and show you the
yes video will be very helpful if we can do that. And
okay sir. রাতুলকে ডেকে নিতে হবে।
yes this is the video.
add video, কি করে ভিডিও অ্যাড করব? এখানে তো ভিডিও অ্যাড করা নেই।
স্যার
হ্যাঁ
বলছি এখানে ভিডিও যদি আপনি অ্যাড করতে চান, ভিডিওটা কি আপনার ল্যাপটপে বা কম্পিউটারে আছে?
কম্পিউটারে আছে।
হ্যাঁ, আপনি অ্যাড আ নিউ ভিডিওতে যান, এখানে আপনাকে ইউআরএল দিতে হবে, তা না হলে কিন্তু অথবা স্ক্রিন শেয়ার করতে হবে, না হলে কিন্তু আপনি ভিডিও প্লে করতে পারবেন না।
ও
এটা যদি কোনো অনলাইন ভিডিও থেকে থাকে আপনি এখানে ইউআরএল দিতে পারবেন।
না অনলাইন ভিডিও মানে আমার ভিডিওটা হচ্ছে যে আবার হোয়াটসঅ্যাপে আছে।
আচ্ছা না না সেটা করা যাবে না, আপনাকে তাহলে এখানে স্ক্রিন শেয়ার অন করতে হবে।
ওকে ঠিক আছে স্যার, আমি ভিডিওটা লাস্টে দেখাচ্ছি।
ওকে
এই জিনিসগুলো আগে করে নিচ্ছি। So on day 10, sir, there this SOB has decreased, oxygen requirement has decreased. The hemodynamically, though it looked like a stable, but remember patient was hypertensive, so a little bit BP is on the lower side. Otherwise, the patient is normal. On the day 11, new onset of fever spike and the oxygen requirement increases. So what next? So it may be a secondary infection.
yes
So we are searching for the secondary infection. So we have sent in the French culture and also all the markers. And this is not the respiratory ICU, it is a COVID ICU. So we have shifted the patient from HDU to ICU. We have given the IV fluid and other supportive measures to maintain the MAP more than 75 because the patient is hypertensive. And the total count is 16,000. Poor calcitonin is 2.9, and the sputum showing that gram-negative GNV. So there are some evidence that tocilizumab in patient with hospitalized with COVID pneumonia, and showing that it increases the secondary bacterial infection. Uh, it has been published on the July 2020. And also, this is a microbiology, clinical microbiology and infection journal. It's showing bacterial co-infection or secondary infection patient with COVID-19, and it is a meta-analysis report and showing that in COVID there is a severe decrease of the immunity, and the host is behave like a immunocompromised host. So they are very high prone to develop secondary bacterial as well as fungal infection, and we also seen this in practical life. So secondary organizing pneumonia followed by viral pneumonia. It is an old paper. It published in 2017 at the pandemic situation of the influenza H1N1. So post-viral bacterial infection is very common, and we found that the patient put on growing the Klebsiella, and it was intermediate sensitive to meropenem and sensitive to colistin. So what now there is a question whether we go for the single colistin or colistin with meropenem combination or others. So we go for there are multiple evidence that combination therapy is better than the monotherapy, though there is a school of thought that monotherapy, targeted therapy is better. But there are evidence that combination therapy is much better than the monotherapy. We started meropenem and colistin, and we continue other conservative treatments. And there are a lot of debate regarding what will be the duration, IV duration. Usually, we follow that for if it is a invasive, if it is a bloodstream infection, we continue the IV antibiotic and we send every 48 hours the blood culture. And after negative of the blood culture, we continue the 48 hours IV medication. And then as per the procalcitonin trend, we de-escalate the bacterial antimicrobial agent. Here we continue 7 days treatment and patient improve. And on the 9th day of secondary infection, patient is in room air saturation 96, total count go little bit higher side, but procalcitonin and CRP come down, under control. So we have shifted to what? Then after we have discharged the patient. Thank you. So this was my first case.
Video, can you show the video of the CT?
Yes, sir. Just a minute. I'm trying. Ratul, can you help me?
Hello, sir.
রাতুল
স্যার ভিডিওটা দেওয়া রয়েছে এখানে, প্রিভিউ ভিডিও দেখাচ্ছে।
কোথায় দেখাচ্ছে?
দেখুন ভিডিওস বলে অপশন যেটা রয়েছে,
ভিডিও। হ্যাঁ,
ওখানে আপনি ভিডিও দেখতে পাচ্ছেন?
না, ভিডিও আপডেট হয়নি বাবু। হ্যাঁ, ওকে ওকে, থ্যাংক ইউ।
ওকে।
Yes, sir.
Thank you.
আদিত্য, শোন না, সেকেন্ড কেসটা তোকে যেটা পাঠালাম ওটা একটু আপলোড করতে বলো স্যার। অশোক স্যার,
হ্যাঁ আমি আছি।
আপনি ভিডিওটা অন করে লাইভ আপনার আমরা এই কেসটা নিয়ে ডিসকাস করি, তারপরে
Okay, I am just starting. Now, that's a very good presentation, but you have been a bit lucky in this case. It is a fairly straightforward case when the patient presented with COVID pneumonia. It was very evident in the CT scan with peripheral ground glassing, and there is some patchy consolidation, mostly distributed in the peripheral subpleural areas, which is sort of hallmark of COVID invasion of the lung. And as you stated, that COVID itself induces an immunocompromised state, and that has been further compromised with the introduction with the patient receiving tocilizumab and plasma, convalescent plasma, and the patient developed two telltale signs of a fresh infection, nosocomial infection, increased oxygen demand, fever, etc. And the microbiology department has got a very good job here. They have isolated a drug-resistant Klebsiella, which is sensitive only to colistin, and that's a fairly straightforward case. The patient responded to further NIV support and addition of colistin and combination meropenem has helped the situation from a very otherwise gloomy situation. I am glad that the patient finally cured and went home. But on many occasions, we do not see such straightforward cases, especially when there are certain special type of infections in this post-COVID or post-immunocompromised post-status. For example, we have to have a very high suspicion of fungal infection. And in our experience, fungal infection, you have to have a very high suspicion. That high level of suspicion is the only thing which can help the patient and the situation. For example, in this particular case, had it been a fungal infection, you would expect a gradual rise in the white cell count, patient not responding or just holding on there with a bit of hypoxia, but persistently sick, and procalcitonin may be borderline high or even with the normal index. In those situations, probably we have to go for another CT scan of the chest and try to find out if there is any fungal evidence of fungal infection, for example, aspergillus, certain etc., which will be consulted by the radiologist. But in this situation, if we have to think about fungal infection, then there is a scope of even empirical broad spectrum antifungal, or if we are lucky, if the bacterial or if the fungal culture of the sputum or the tracheal secretion is positive, then we should go for it is just I wanted to make the concerned doctors a little bit more suspicious about the possibility of fungus and need to add or need to think beyond the bacterial zone in this case. But this is a straightforward case, and I'm glad that the patient went home.
Dr. Iqbal.
Yes, sir.
What was the status of diabetes?
Sir,
it was controlled all along.
No, actually, we have not given the details of the diabetes, but initially the sugar level is around 350, but during the treatment course it increases, but we have control with the bolus and the basal dose. We use as a long-acting insulin Lantus and the sliding high and medium scale slidings depending upon the sugar scale. Our target is to maintain the sugar 140 to 180 this range. Yes, sir.
It was steady and it was maintained.
No. That was little bit fluctuating sugar level, but we have control with the this insulin, sir.
Okay, again the patient is on steroid,
Yes, sir.
and so that is also should be kept in the
Sir,
back of
we
mind.
also seen the patient develop decay after COVID
Yes,
due to the steroid injection. We
and
have found that
and one learning point is that sometimes the fever spike may
yes,
not be there,
yes,
because diabetes patient, so the temperature response will be dampened, so there will be only the oximetry will go down, your ABG, etc., oxygen saturation. So that is an eye opener, that whether any secondary infection has occurred or not.
yes,
And septicemia is another key issue which we are very much scared of. Septicemia. So these are all points as already alluded by Dr. Sengupta.
yes,
So this fungus, invasive fungus, so this should be always kept in the back of mind. So this is a very eye opener, although straightforward, but eye opener case.
yes, sir.
Okay, thank you. Go to the
Uh,
next.
Sir, can we go forward to next case?
Yes.
Yeah. So next case is a fungal infection. So this is a 70-year male, hypertensive, and also this patient on the amlodipine, but this patient having another disease, that is ulcerative colitis. And for that patient was mesalazine and prednisolone for the long period, and all, and this immunosuppression started for 1 year. So patient presented with a non-productive cough and progressive breathing difficulty, duration only 1 day, and on admission, sorry, on admission, there is a GPCS on admission and subsequently altered sensorium and shortness of breath. Problem. So, in the emergency, patient intubated and ventilated. Then shifted to the ICU, and ABG showing that hyponatremia, maybe this convulsion due to the hyponatremia event. But chest imaging, non-homogeneous opacity, and brain imaging, diffuse ischemic changes. EEG encephalopathy type changes. This is the chest X-ray, and this is the CT. This is the cutout of the CT. So again, the provisional diagnosis may be aspiration pneumonia, LRTI, and we have sent the comprehensive respiratory panel that is negative, and COVID RT-PCR is positive. We have started conservative management. From next day, patient sensorium little bit better after correction of the sodium, and patient extubated, start NIV and the supportive care. And due to the COVID pneumonia, we have this is also again the 9th day of disease. Volume 9th day of disease, and we have started TOSI, steroid, Clexane, and the remdesivir. On day 4 ICU, there is a development of the respiratory failure, and we intubate, ventilate. And day 8, there is a fever spike and oxygen requirement. So obviously the patient going to the secondary infection. So we have sent all the necessity cultures, and along with the serum galactomannan and PCT. Pulmonary sequelae, there are evidence of pulmonary sequelae in patient recovered from the swine flu, develop the invasive aspergillus. Though there is a case report also in a COVID-19 patient in the month of July 2020. This is a fatal invasive aspergillosis in a coronavirus disease immunocompetent patient, and we like this is invasive aspergillus slide, though it is not my slide, it is a NEGM slide. And also there are American Thoracic Society also having the article on the COVID-19 associated pulmonary aspergillosis. So routinely we have sent the blood CS and all blood sputum and all. So these are the evidence for development of invasive aspergillosis post-influenza patient. So invasive fungal infection associated with respiratory viral infection, immunocompromised host, also there is evidence. So we have found that this patient developed the aspergillus, we have identified the aspergillus, and invasive fungal infection it is a global burden for the respiratory, especially in the respiratory, the lung crippled patient. And we know that invasive candidemia, if you see the invasive candidemia, it is increasing day by day. So there are certain risk factors for invasive fungal aspergillus, that is neutropenic or post-transplant or immunocompromised patient. And risk factor for candidemia, that is a very critically ill patient, patient with a poor nutrition, patient with the invasive line, pancreatitis, diabetes, hemodialysis. And the risk factor for invasive aspergillosis, immunocompromise is the highest, and the most of the COVID patient, they are the immunocompromised. Directly they are the, if they're having the comorbidity, or we are giving tocilizumab, we are giving steroid, we're making them immunocompromised. So galactomannan is a indirect examination to for the aspergillus, and for the candida 1,3-beta-D glucagon, and direct examination microbiology. Though we have identified one case, though I have shown you the slide from the NEGM, but one of our patient we got this type of slide. So the mortality, if you not diagnose properly or not diagnose early, the invasive fungal infection, sometimes it is very fatal. And the timing of intervention, it dictates the improvement. I mean, how fast you are reacting, how you will be the success, how it will be successful treatment. So you can suspect the you can suspect the cases by doing the Candida score, or for treatment it is you can give prophylaxis for a high risk patient, or where there is risk factor you can give the empirical treatment, preemptive or targeted therapy. So this is the antifungal agent we all know. And guideline recommendation for patient with a if it is a hemodynamically compromised patient, then echinocandin is the best choice. Or if it is a hemodynamically stable patient, no history of azole exposure, you can go for the fluconazole. and the patient characteristic echinocandin is if you see the echinocandin for non-albicans, it has a good range. And if you compare with the MIC value, the micafungin, caspofungin, and anidulafungin is more comparable. So in this case, we have started the micafungin for invasive aspergillosis, and ultimately this patient is not survived, sir. Thank you, sir.
Yes, Asif. Have you finished?
Yes, sir.
Okay. Yes,
yes, sir.
As we have seen, as we are talking through the first case, that though the first case was a secondary bacterial infection with MDR Klebsiella, but always our suspicion should remain very high. And in the second case, as you have seen that particular slide where with every hour the mortality rises if you do not start the antifungal agent in an appropriate time. It is very similar to invasive bacterial infection where choice of antibiotic and onset of the start of antibiotic treatment is of extreme importance. With each hour, the mortality rises proportionately. And so is with the fungal infection as well, because here, though we have isolated the fungus aspergillus, but by that time, probably it has spread in the majority of the vital organs, and the patient finally succumbed. So again, for our junior colleagues, the suspicion should be very high. Whenever the patient has stopped responded after an initial apparently successful antibacterial treatment, the procalcitonin is hovering around borderline or even normal range, then please think about fungal infection, and especially in the event of prolonged steroid use, immunocompromised situation, for example, use of tocilizumab, use of steroid, this particular COVID-19 virus itself is an immunocompromised inducer. So this is a perfect scenario for invasive fungal infection. And as you have shown in that particular slide where there are options of empirical or preemptive treatment, empirical treatment can save a lot of life where there is the doctor suspects about fungal infection even before the culture, etc., is on, even before the blood markers are reported. So that should be the high level of suspicion, and quick onset of action can save our face to save the patient. Good example, good learning point. Thanks.
Thank you, sir. Sir, there is a question from Mr. Arindam Mitro, Dr. Arindam Mitro. He said that whether we will start empirical antibiotic when we are starting the Tosi remdesivir
Antibiotic.
Steroid antibiotic.
Well, we have to see the whole scenario. The patient is immunocompromised. He is in an ICU setup. He has been given steroid, tocilizumab, etc. We can very well compare with this patient with a patient who is undergoing chemotherapy with neutropenia or severe leukopenia. In those cases, after 3 days of initial standard antibacterial treatment, if they do not respond, we should go for higher spectrum, as well as think about antifungal. Yes, I think one can defend the situation that this patient, once you start giving them steroid, tocilizumab, etc., they should be protected with broad spectrum antibiotic, and we have to go for repeated cultures, etc., until the microbiology lab helps us to some extent.
So another question, when should we start antifungal in a COVID patient, empirically?
Empirically, as I said earlier, we have to have a very high suspicion level. The patient is still sick, oxygen requirement is still high, procalcitonin may or may not be helpful. The radiological improvement is marginal or even worse, and the patient is on adequate broad-spectrum antibiotic coverage for a sufficient duration of time. This is a particular scenario where you need to think about empirical antifungal treatment. In my situation, I usually go for caspofungin or micafungin, as you said. The micafungin is probably should be the drug of choice, broad spectrum wise. And once, if we are lucky, if we can fix the organism, if it is aspergillus, then we can always switch on to the azoles, for example, voriconazole.
Yes. So another question here that for TOSI and the CCP, the question is whether both is needed or not.
Well, actually, there is no clear-cut answer to this because it's a relatively new disease. We are learning about this particular novel virus every day. Every day, the outlines are changing, and we have been given new instructions, new medications, and old ones were discarded. So, what would be the guidelines say as far as the TOSI and CCP combination?
Sir, honestly speaking, there is no clear-cut guideline.
Yes, exactly.
regarding
That's why I put it to the audience. I will Professor Basu.
Regarding CCP, there is a lot of controversy whether CCP is effective or not. The last recent paper in the NEGM regarding the CCP said that if the antibody develop in a patient, then CCP has no use. That's why the cutoff date is onset of disease, 9th day of the disease actually. So it is sometimes it very difficult to rightly diagnose the day of disease.
Yeah.
In Indian scenario or in Calcutta scenario, sometimes it is very difficult to predict whether it is exactly a 5 days disease or not. So in the SSKM, they have made a guideline that for the trial, they are sending the antibody titer. If there is no antibody, then they are giving the CCP.
Right. So again, it depends upon the scenario. If we get a proper history from the patient, if we can actually pinpoint the duration of the illness from the history, etc., then it will be a bit of help. Otherwise, as SSKM suggested, we should go for this measurement of antibody titers, which is again not very easy to do in all hospitals. There are certain limitations, logistic problem, infrastructure, etc. So taking everything into picture, again, I think a combination at this stage should be reserved for those who are desperately ill, and it is probably the clinician's discretion whether to go ahead with the combination or not.
Sir, one more question. This will be the last question. Actually, one question here is that is there role of second dose TOSI? Most of the center they are giving 2 dose TOSI. So in our experience, we have given initial days we have given second dose, but we have seen that multiple the secondary infection it makes more immunoparalyzed to the patient.
Yes, you are absolutely right. In our experience in Apollo Gleneagles Hospital, a first dose tocilizumab actually knocks down most of the immunocompetence of the patient. And if the patient is still desperately ill, it will be a difficult scenario to think about a second dose of tocilizumab and further knocking out whatever immunocompromises he or she has. Difficult, but probably we should avoid it, especially when you are thinking about possibility, a very high possibility of inducing another infection, either bacterial or fungal, in a particular case.
Thank you, sir. So,
Dr.
anybody, any
Iqbal,
other question?
Dr. Sengupta, I have a question to Dr. Sengupta.
Yes,
Yes,
please.
sir.
Is there any documentation of pneumocystis carinii in a setting of COVID? That is also a very problematical.
I am sure there are examples in the literature, but in our center, I don't think we have isolated pneumocystis carinii infection. But as you know, pneumocystis carinii is a settler in immunocompromised lungs. So one has to be careful about that. We can think about it, but so far in our hospital, as I know, we haven't got a single case of pneumocystis carinii so far. But you are
No,
right.
but you have documented cases in Calcutta or in India.
I am not aware of that. Sorry, sir.
But there is a possibility.
Oh yes, yes, absolutely. There is a possibility. One has to be alert about it.
Sorry. Thank you.
So, any question from audience? Manjur?
Dr. Apurbo, Secretary, IMA, New Barakpur, Muddumgram. Has you got any queries or question or something to say? Because the learned speakers, Dr. Sengupta is here, so we can utilize his presence and get some learning points. Dr. Apurbo? Any doctor from New Barakpur, Muddumgram area? So Dr. Iqbal, is any other presentation?
No, sir. That's two presentation actually. Is Apurvada online?
I can't make a phone call and then call. We can find out the program.
Yes, sir. অপূর্বদা তুমি অনলাইনে আছো? হ্যাঁ, না সেটা কোশ্চেন পুট করেছো, ইয়ে করছিলেন, কথা বলছিলেন, তুমি অ্যান্সার করছো না। আশিস কুমার স্যার হচ্ছে যে কোশ্চেন করেছিল, মানে তুমি না তুমি ইয়েতে কথা বলো না, তোমার ওখানে মাইকটা অন করো না। স্যার অপূর্বদা অনলাইনে আছেন?
So Apurbo, have you got any queries, questions? Because Dr. Sengupta is here, we can have some guidelines and ideas, because it is very necessary, crucial, and it is a multidisciplinary approach. Good microbiological setup is a must.
Yes,
is a must.
It's very helpful.
Very helpful. And the clinical monitoring, follow-up, etc. And Dr. Sengupta, one thing is very rather very problematic, and we are also worried that post-COVID phase, patient, Dr. Iqbal had discharged the patient.
Yes.
In the post-COVID phase, so that should be a clear-cut follow-up.
Absolutely.
Otherwise, the post-COVID complication, we have lost few of our colleagues In medical college, we have lost one professor, associate professor in neurology. Post COVID state, he developed suddenly
Cardiac arrest. Yeah.
cardiac arrest. So that is very important. Post
Extremely
COVID follow
important.
up.
Very important. Cannot agree
Uh,
more.
that's why you in Apollo we have a post COVID follow up clinic,
Yes,
etc.
yes, yes. We do
So
have, sir.
so that is the rule of the thumb.
Yes. Yeah.
Because otherwise and again, if the patient is apparently cured, oxygen saturation is okay, it is quite fit for discharge. Sometimes the pulmonary fibrosis develops, so patient, if he does not follow some breathing exercise, etc., then pulmonary fibrosis will be a chronic problem, and that is that needs addressal.
Yes,
So
yes, absolutely. In our
pulmonary
in the post-COVID cases, whenever they come to us, we have seen a very big jump in two things. I'm not a cardiologist. The cardiologist can tell us about their problems, but huge increase in the number of post-COVID lung fibrosis. That is number one. And what is state is in shatters.
yes, yes,
So
yes.
that is also a very important thing that the
Yeah, yeah,
psychiatrist should be aware of.
yeah,
We
yeah.
deal with lung fibrosis and we are trying our best. But again, that will be another chapter to discuss in future.
Post COVID, some dementia and psychosis,
Yes,
etc.
and very high level of anxiety.
High level of anxiety. So sometimes antidepressant has to be added,
Depression, anti-anxiolytics, yes.
anti-anxiolytic state, etc. So again, the metabolic parameters. Myself being endocrinologist, we look into the metabolic. We are worried about the metabolic parameters as
Yes, absolutely. Especially liver function
yeah,
test, deranged liver
yeah,
function test.
yeah. Metabolic parameters, liver, kidney, and diabetic status,
Yes.
etc. So otherwise, we have seen few cases the COVID positive, then this on discharge COVID patient well, the COVID negative. Again, after a couple of weeks, developed the same thing down the line, became COVID positive.
Yes, yeah.
Yes, sir.
So this is some questions put forward to you. Why those patients? I think again they become COVID positive, and down the line they develop the complications, and some cases have already succumbed also.
Yes, the
So
reinfection rate is documented, but the percentage is rather low. It's not that prominent, but we are very concerned about two things. One is lung fibrosis, as I said earlier, and the second is venous thromboembolic events.
yes, that is
Yes,
very
sir.
Many patients who are discharged even after 10, 15, 20 days or even months, 1 month, 2 months, the D dimer tends to be very high. And on discharge, we usually give some non vitamin K dependent newer generation anticoagulants, for example, apixaban, etc.
We have lost 3-4 patients with post-COVID lung fibrosis, and these are the patients behave very badly with they are very high prone to develop secondary infection.
yes,
This is post-COVID lung fibrosis. This lung is very notorious. We have recently lost two patients.
yes.
Sir, welcome, Dr. Subhasis. They are also online.
Mm, One thing I would request Dr. Iqbal.
Yes, sir.
I believe that you are maintaining this protocol also,
Yes,
as
sir.
already alluded by Dr. Sengupta.
Yes, sir.
and shared by myself also,
Yes,
that
sir.
post-COVID follow-up is very crucial, because the lifestyle and
Sir,
all these things became
we have started
totally altered.
recovery clinic for the post-COVID patient. We have started already under the guidance of Dr. Asok Subhasis, Ghosh sir, and also our other pulmonologists. We have started the post-COVID recovery, and the post-COVID patient not only they are suffer for the lung problem only. They have a
Yes,
psychological imbalance. They
yeah,
have a
that
problem.
everything.
They have a back, very bad back pain.
Mhm.
Sir,
And this is
another one question has given Dr. Manjur Alam in our junior. Yes, asked for the post-COVID MRI myocarditis. Could we start every patient antiplatelet therapy? Uh, is there Subhasis sir online? Also, sir,
Yes.
sir, you have to ask.
Yes. Give me the question again, please.
Sir, the question is for the post-COVID MI or myocarditis patient, we should always start antiplatelet therapy because we are giving the heparin, low molecular weight heparin, so we will start antiplatelet in this patient.
Well,
Especially the myocarditis patient. We often found the myocarditis in the COVID patient.
I am not aware of any particular guideline, but there is myocarditis and this patient needs to be started on antiplatelet. Myocarditis actually is not easily diagnosed. You have to have certain parameters, for example, rise in cardiac enzymes and fall in ejection fraction, etc. There could be certain other echocardiographic findings which may point out to the diagnosis. If there is a definitive myocarditis, I am not very sure, not aware that one has to start antiplatelet therapy. This is anyway, we have to go for cardiologist's opinion here. And again, COVID, as I always highlight, this is a new disease. None of us have got a very good experience about the organ involvement, especially vital organs like heart or lung. So one has to depend upon experience, anecdotal treatment experience, etc. So it will be a cardiologist call to start antiplatelet at all. I am not aware of any guidelines regarding this.
Okay, thank you, sir. So then we should close this meeting.
Yes, we can wind up
Any
this
other
meeting.
question? No
Dr.
question in the
Iqbal.
question box. Yes, sir. Yes,
Hello.
Hello.
yes, sir.
Dr. Iqbal.
Yes, sir.
So actually, what is the actual time to start with steroids? Which course level
Okay.
we should start?
No, actually, we start the steroid in a patient with a if you give a CT severity score, moderate to severe disease, or the patient is having the oxygen requirement. We do not
Huh?
give steroid to all patients.
Only hypoxic patients.
Do not give steroid to all patients.
Okay.
What is Sam's opinion? So, what is serious guideline also? And officer, sir, after opinion, that is the steroid? Because as per the research but also increase the mobility, we give the unnecessary steroid. Or those patients who does not require oxygen therapy, Also, sir, please.
Well, as we know, so far the guidelines have suggested that steroids should be reserved only for those patients who have a definite documented in arterial blood gas. I don't think CT scan finding should be a marker for using steroids.
Yes.
Hypoxia is our guideline.
Okay. Okay, thank you.
Thank you.
Dr. Apurvo.
Yes, sir.
Apurvo.
Yes, sir. Yes, sir.
So let us wind up then, and our sincere gratitude and thanks to the learned speakers, Dr. Sengupta, Dr. Iqbal, who have thrown light on different aspects, and the important point which has surfaced that post-COVID follow-up is very, very important, and it should not be, we should not be complacent when we discharge the patient because the patient is now stable. That does not mean that the patient is out of danger. So that is a very carry-on point from Dr. Sengupta and Dr. Iqbal. So with this, I think we can wind up our discussion. Our profuse thanks from IMA New Barakpur Muddamgram, and on my behalf, personal behalf. Basically, I'm an endocrinologist, but I opted to join the webinar because I already knew Dr. Sengupta. So, a lot of good points and exchange of thought. So that is the need of the hour. This is an exchange of thoughts. So a lot of things they have made it clear. So in future, I think we'll try to hold such type of discussions for the greater benefit of our society. So
Thank you, sir.
Thank you, sir.
Thank you, everybody.
Thank you so much, sir. We are honored to experience the scenario of eminent faculties, Dr. Asok Gupta, Dr. Subhasis, and Professor Dr. Ashish Kumar Basu as a panelist and Dr. Asif Iqbal as a moderator. We also thank our viewers and participants for their presence to make this session a great success. Kindly like our Facebook page for the Auxiliary of Academy and HCP Forum for more activities. At last, we would like to thank HCP Forum for associating with us. Thank you all.
yeah.